Okay, so in this video I'll be talking about cardiac arrhythmia, different types of cardiac arrhythmia, their ECG findings. I recommend you to watch the full video to get the most benefit out of it. First of all, what is cardiac arrhythmia? Cardiac arrhythmia is defined as disturbances in the electrical rhythm of the heart. It is simply divided into two types, tachycardia and bradycardia. Tachycardia is when the heart rate is more than 100 beats per minute, and bradycardia is when the heart rate is less than 60 beats per minute. Now let's see the different types of cardiac arrhythmias. Cardiac arrhythmia is simply divided into two types, tachy and brady. Tachycardia is further divided into narrow QRS tachycardia and wide QRS tachycardia based on the QRS complex. If the width of the QRS complex is more than 3 small square on the ECG strip, then it is called wide QRS complex. Now, wide QRS complex tachycardia consists of VT, antidromic AVRT, supraventricular tachycardia with bundle branch block. Out of them, VT is the most common and which is a medical emergency. Now, narrow QRS complex tachycardia is where the width of the QRS complex is less than 3 small square on the ECG strip. Based on the pathophysiology of the mechanism, it is divided into three categories: re-entry phenomena, altered automaticity, and abnormal atrial rhythm. Re-entry phenomena consist of AVNRT and AVRT. AVNRT stands for AV nodal re-entry tachycardia and AVRT stands for atrioventricular re-entry tachycardia. Altered or enhanced automaticity consists of focal atrial, multifocal atrial, and junctional tachycardia. Abnormal atrial rhythm consists of atrial flutter and atrial fibrillation. Now, bradycardia consists of SA node dysfunction. Either it is SA nodal dysfunction or AV block. Out of them, AV block is very common. Also, AV block consists of first degree, second degree, and third degree AV block. SA node dysfunction, sick sinus syndrome is seen in elderly patients. Okay, on your screen you can see the ECG of AVNRT, AV nodal re-entry tachycardia. Here you can clearly see that it is a narrow QRS complex tachycardia where there is no P wave. The P wave cannot be appreciated in this ECG. This is a classical finding of a supraventricular tachycardia. Now, AVNRT and AVRT, both of them have mostly similar type of ECG finding. You don't need to particularly differentiate between these two in clinical setting because both of them have the similar treatment. Now let's move on to the next ECG. Now on your screen you can see the ECG of focal atrial tachycardia. It is also a narrow QRS complex tachycardia where the P wave morphology is different from the normal. P wave is downwards and it is retrograde P wave, which is not normal morphology. So the impulse is being generated somewhere else other than SA node. Also, you can appreciate that the morphologies of all the P waves are similar, which implies that the impulse is being generated from a single focus, not multiple focus. This point will be helpful to differentiate MAT, multifocal atrial tachycardia, from this focal atrial tachycardia. Okay, let's move on to the next ECG. It is a MAT, multifocal atrial tachycardia, on your screen. You can see the narrow complex tachycardia with different P morphologies. This is a classical finding in a multifocal atrial tachycardia. Let's move on to the next one. On your screen you can see junctional tachycardia. Now, junctional tachycardia is quite similar with the AVNRT. The only difference is that the rate of the tachycardia is slightly less in junctional tachycardia, which is less than 130 beats per minute. But in case of AVNRT it is higher. It is normally more than 180 beats per minute. But otherwise it is quite the same. There is no P wave that can be appreciated in this ECG. Now on your screen you can see atrial fibrillation above and atrial flutter below. The characteristic sawtooth pattern is seen in atrial flutter, and in case of atrial fibrillation, the fibrillatory wave. The RR interval are irregular in atrial fibrillation. Also, there is no P wave that can be identified in atrial fibrillation. On your screen you can see the VT ECG of the VT. There is positive or negative concordance in lead V1 to V6. This is how VT looks like, wide complex QRS tachycardia. Now let's move on to bradycardias. Now let's just look at the AV blocks. I'll quickly show you the AV blocks. This is the first degree AV block. The PR segment is longer than usual. It is more than 5 small squares. So this is first degree AV block. Second degree AV block, this is Mobitz type 1, where the PR interval progressively prolongs, and after that one QRS complex misses. This is Mobitz type 1. And so this is Mobitz type 2, where the PR interval is constant, unlike Mobitz type 1, but QRS complex is missing. In third degree AV block, we know that no impulse goes into the ventricle.